This morning, we are really privileged to have our own Dr. Benn presenting at our grand rounds today. Let me just make sure okay, not me, sorry. So Dr. Benn is an associate professor in the Center for Biostatistics and Department of Population Health Science and Policy, as well as the founding director of the Center for Scientific Diversity at the Icahn School of Medicine at Mount Sinai. She's also the director of data science training and enrichment in the Graduate School of Biomedical Sciences, and serves as a member of the Quality Leadership Council, Faculty Diversity Council, and Anti-Racism Task Force at Mount Sinai. She's also served as the co-director of the Master of Science in Biostatistics program, as well as the director of academic programs for the Center of Biostatistics. She's collaborated on a number of health disparities related research projects over the course of her career, and also teaches a graduate level course entitled Race and Causal Inference, which we'll be hearing about more today. And this is really aimed at increasing the methodologic rigor by which we investigate health disparities with a goal of finding effective causal targets for intervention. Dr. Benn is committed to increasing diversity, inclusion, and equitable advancement in biostats and STEM fields, and more broadly, as well as reducing racial ethnic disparities in faculty promotion in academic medicine. She currently serves on the American Statistical Association Anti-Racism Task Force, as well as a Sexual Harassment and Assault Task Force. She's the co-founder of the National Heart, Lung, and Blood Institute-funded Biostatistics Epidemiology Summer Training Diversity Program, and a former chair of the Eastern North American Region International Biometrics Society Fostering Diversity in Biostatistics Workshop. She served as a mentor for the Joint Statistical Meetings Diversity Workshop, and as well as mentoring program and the Math Alliance. She was the co-PI of the NIGMS-funded Applied Sciences in Biological Systems short course, aiming at increasing the statistical competency and research capacity of early-stage researchers nationwide. She's currently the co-PI of the National Human Genome Research Institute-funded Clinical Research Education in Genome Science short course, which is aimed at exposing doctoral students, postdocs, and clinical and research faculty to computational tools in genome science, in addition to effective strategies for engaging underserved communities in genomics research. Her contributions to diversity and inclusion in statistics and STEM have been celebrated by various organizations, including Mathematically Gifted and Black and the American Statistical Association. So it's really our privilege to have Dr. Benn here this morning speaking to us on race and causal inference in health disparities research that I'm sure a lot of us are starting to engage with amongst the different GI disease pathologies. Thanks for joining us, Dr. Benn.
Thank you for inviting me. I really appreciate the opportunity to get to speak to you and your colleagues. And I hope that what I will be speaking about today will have relevance to the work that you are doing, or just kind of, I don't know, make you think outside of the box a bit. And maybe some of you already have been thinking about race in biomedical research, how we operationalize that. But I think it's important for us to kind of think about it sometimes from a statistician's perspective. But my hope is to engage everyone in discourse around this. So yeah, I'd like to get through my lecture, but I'd actually rather be able to have a conversation with you. And that's more interesting to me. And so at any point, if you have thoughts, whatever, we can just feel free to chime in and let's talk. Okay, so I'm going to share my screen now. Can all of you see my screen?
Yes.
Okay, wonderful. So today I'm going to talk about race and causal inference in health disparities research. Just letting you know, once again, my name is Emma Benn and my pronouns are she, her. I've been thinking about this a lot in my career. So I need to just give you a little bit of background. Yes, I'm a biostatistician, but I did not actually come into public health assuming that I was going to be a biostatistician. I actually didn't even take my first biostatistics course until I was getting my master's of public health in what was called, and what is socio-medical sciences at Columbia University. And I had come into that field thinking that I wanted to better understand how we embody isms. How do we embody inequitable structural systems, right? And that's why I came into the field of public health. From a background in chemistry. So I have a very nonlinear trajectory to biostatistics. But when I got exposed to biostatistics, I realized that that was a really interesting tool to draw inference about important research questions around disparities. Now, not all of the work that I do is around disparities. I get to work on a variety of collaborative research projects. However, I will say that my passion is health disparities. And while I have been doing this for quite a while, I think that there was a point in my career, maybe a few years ago, when I kind of hit this philosophical dilemma. And kept thinking about the fact that we do really, really well at describing differences, but actually eradicating health disparities, reducing health disparities, we don't do nearly as well. And I kept wondering what I needed to do to educate myself around how I was thinking about the way in which we do research in health disparities. Okay, so I just wanted to give you some context and help you to understand that what I'm sharing with you is a lot of what I learned in the research that I was doing to try to better understand this. And I think currently thinking about COVID-19, I think COVID-19, for many who weren't even thinking about disparities, has now kind of provided a platform, unfortunately, to begin to think about the inequities that exist and what might be the causes, such that we are going beyond just COVID-19 and really thinking about what is it that's going on that makes particular populations more vulnerable, and how do we intervene? So let me just give you an overview. I'm going to define this kind of circular slump that I didn't really coin that term. Actually, Kaufman coined that term, but defining this kind of circular slump in racial ethnic disparities research. Give a brief introduction to causal inference. I mean, causal inference is a whole field within itself. People spend years trying to learn about causal inference. I'm going to give you a very brief introduction that will help us understand more about how we contextualize race. And also, I have some questions to facilitate discussion, but that's really if nobody has questions, right? I'm going to assume that this is an audience that is quite engaged, and so I imagine you'll have your own questions. So just to let you know, if you're interested, you can check out a commentary that me and my colleague Keith Goldfeld, another biostatistician who I actually train with, who's currently at NYU, we wrote a commentary on translating context to causality in cardiovascular disparities research. And I also, as you mentioned earlier, do teach a race and causal inference seminar that I developed a few years ago, specifically for biostatistics students. But what I realize is that quite a few people wanted to learn about this. So I've taught to residents and also to those in the PhD programs. So let's just start with a motivating example, okay? So a researcher sets out to estimate a measure of the strength of the relationship between race and, let's say, hypertension, right? She controls or adjusts for factors associated with both race and hypertension, factors like maybe access to healthcare, educational attainment, things like that, in an effort to get an unbiased effect of race. The researcher subsequently constructs her statistical model, right, and gets some adjusted estimate of the effect of race on hypertension. If you were to ask me what this researcher has learned from the results of her analysis, I'd say not very much, okay? And that really ends up being the focus of this lecture. Why would I say not very much, especially if this is the process, or this is the strategy that we're taught? I mean, from the beginning, you know, when we're taught about health disparities, we're taught that we should be looking at racial differences. But my lecture today will try to tap into why that researcher perhaps didn't gain very much from that analysis. So look, good research, I mean, look, I'm talking to a group of folk who are great researchers, right? So I'm probably just preaching to the choir. But good research always starts by stating your research question, right? In our motivating example here, the research question most likely was, is there a racial ethnic difference in the risk of hypertension between Blacks and whites? And you could put in any disease there. This is kind of the standard question that I see a lot in health disparities research. We typically state our null and alternative hypotheses. I hope that for those who have taken statistics before, I hope that you had a great experience with statistics and I'm not bringing back bad memories. But ultimately, in Statistics 101, we talk about null and alternative hypotheses, right? Where our null hypothesis is our status quo, right? And what is our status quo here? That the risk of disease in Blacks is equivalent to the risk of disease in whites. And I'm not saying that Blacks and whites are the only racial ethnic groups, but I think for simplicity purposes, to make sure that you're understanding the fundamentals here, I'm working with two groups, okay? So there's no difference. That is our null hypothesis. And the alternative is that the risk of disease in Blacks differs from the risk of disease in whites. So typically we would next power our study to detect a clinically meaningful difference. Sometimes we refer to that as delta. Sometimes you talk about your effect size, right? Given our hypotheses. And then we sample from the population, we collect our data, conduct an appropriate analysis, and potentially conclude we have sufficient evidence to suggest that the risk of disease differs between Blacks and whites with some magnitude at least as big as the clinically meaningful difference that we expected to detect. Do we get any closer to fixing the problem? Well, according to Kaufman and Cooper, no. And Kaufman is a biostatistician, Cooper, I believe, an epidemiologist. They were writing about this in 1995. Of course, I never even got exposed to their work until several years ago. So I kind of wish I had have gotten exposed to this while I was doing my own training in biostatistics. So what do Kaufman and Cooper say? They say when we set out to measure phenotypic traits in Blacks and whites and find them different, we conclude that Blacks, and I'm going to say it could be unintentional conclusion, but we conclude that Blacks are different because they are Black. This conclusion reinforces the belief that biology is consistent with the social definition of race, namely distinctions on the basis of skin color. In practice, however, Kaufman and Cooper go on to explain, we observe that population distributions of disease vary on the basis of skin color. If we pick a physical characteristic other than race at random, we cannot replicate the same degree of variation in disease occurrence. And they say, okay, let's consider blood type, right? There are few population differences in the distribution of common diseases along this axis, right? Most people would be like, if we find a difference in the distribution of lots of diseases on blood type, many people would be like, blood type really isn't the cause here, right? There's something else going on. But to believe that skin color has a unique association to outcomes ranging from IQ to blood pressure to prostate cancer by sheer chance is a questionable if not preposterous, proposition. Now, when I read Kaufman and Cooper, I was like, oh my gosh, like this is gangsta. Like I had never, ever been exposed to statisticians talking about race in research, and challenging our operationalization of race in research, and having a strong opinion about this. They went on to coin this concept of circularity, where they state that our efforts to understand social factors have the effect of emphasizing racial differences. And we are often stuck in this circular slump that gets us no closer to fixing the problem, because ultimately, when we are doing disparities research, it should not be our goal to describe the differences. Our goal should be to fix the problem. Maybe it's going to take a few steps to get there, but that has to be the goal in the back of our minds to guide us as we're doing this research. And we're stuck in this circular slump because we hypothesize that there are racial differences, right? And a lot of times that's informed by the world that we are seeing around us. There's an assumption that as scientists, we are objective people. We're doing some objective thing. But much of our understanding about race in society oftentimes informs the research that we're doing and the types of hypotheses we make. So we hypothesize there's racial differences. We reject the null hypothesis, even after accounting for supposed confounders, right? We've powered our study to have enough people in our study to be able to detect the smallest differences and say that they're statistically significant, right? And we conclude that the racial difference is based on something potentially inherent about the biology, genetics, phenotype of race, or we see the standard conclusion that further research is needed to fully understand why we see this difference. Now you may say, okay, this is nice listening to statisticians and epidemiologists talking about this, but who else is talking about this? And I'm pointing specifically, I'm going outside of just the social sciences, right? Because the social sciences are talking about this all the time. But I'm trying to get at some fields that aren't always talking about this. And I turn to Templeton, who's now writing about 20 years after Kaufman and Cooper, Templeton being an evolutionary biologist. And Templeton probably never read Kaufman and Cooper, but ultimately supports them in their efforts to move us away from irrational circular arguments, where Templeton is actually saying, humans are an amazingly diverse species, but this diversity is not due to a finite number of subtypes or races. Rather, the vast majority of human genetic diversity reflects local adaptations and, most of all, our individual uniqueness. In Templeton's paper, he was trying to really ask the question, do different races exist? And Templeton went through kind of all of the science around evolutionary biology, and that this is his conclusion, that we are diverse, but it's not due to a finite number of subtypes or races. You know, traditionally we are taught that it's perfectly fine to evaluate the effect of race as a predictor on some outcome of interest. But another statistician, Holland, who was actually, Holland was a statistician working with the Educational Testing Service. So outside of kind of this biologic sphere, but Holland argued that the race effect that we measure doesn't have any causal interpretation, stating that really causes are experiences that individuals undergo, not attributes that they possess. Causal variables must reflect the possibility of manipulation. They must be mutable. Now, there is a whole host of folk who argue that even if it's not realistically mutable, that race could still be a cause, but I actually disagree. And so does Holland, and so does Kaufman and Cooper. Right. So while race is not a causal variable, unless you can say that the amount of melanin in one's skin is what is causing a difference in the distribution of disease across racial ethnic groups, it can still play a crucial role in causal studies for a few reasons, right? Maybe for descriptive reasons, which is what we see a lot. But Holland states, in my opinion, race can play an important descriptive role in identifying important societal differences, such as those in wealth, education, and healthcare. The attribution of cause to race as the producer of these differences is, to me, the most casual of causal talk and does not lead to useful action. So Holland is really chiming in and basically echoing what Kaufman and Cooper is saying. He's saying we can do descriptive things, right? But that is the most casual of causal talk. Holland suggests that, well, race might serve, might be operationalized well as an effect modifier in which, for example, we understand whether an intervention works differently across racial ethnic groups. Or maybe race is kind of the first step to trying to delve deeper into the effects of important constructs like discrimination and bias. But ultimately, at the end of the day, most times people don't go that extra step, right? They don't go to discrimination and bias. They say, oh, race is a proxy, but ultimately the experience of discrimination is not homogeneous within a given racial ethnic group, right? How they perceive the world around them, their experiences of discrimination may very much vary, right? So saying that race is a proxy for discrimination still doesn't work. You need to test the hypothesis that discrimination itself is causing an increase in disease risk or worse outcomes. So ascribing a causal role to race does not get us closer to change. And I know most people will say, well, no, I don't think race is a cause, but yet that's where we start, right? That's where we always start. And so we kind of are unintentionally continuing this circularity that Kaufman and Cooper talk about. And so, you know, in this, yes?
You said we could interrupt you. Is that okay?
Yes, please.
So, but how do you then tie this back to because the way to tie it back is with education differences, wealth differences, and so forth. And that really is how you get out of that circle, right?
Exactly. But even then, thinking about what is the best way to do this, right? So a lot of times, so it's still understanding what is our counterfactual here. So you're right, education, right? We could imagine that education could be mutable in some way, right? But what I may find is that the impact of education on health may actually differ. The magnitude of that impact may differ depending on what group you're coming from, right? And so what I may find is that education, yes, impacts health, but it impacts health under certain conditions. When education allows you to get good jobs in which you get good access to healthcare and you get optimal housing and you get all of these other things, yeah, education then impacts health. And so what happens is that I completely agree. We need to start with education. But a lot of times we start with race and then we say, okay, well, we'll just adjust for education. It does not mean the same thing as testing whether education has an impact on health. So I completely agree with you. Thank you for the comment. I also think, just thinking more about this, a lot of times, in the public health, sector, yes, many people are trying to focus on education, on wealth, on all of these things. In kind of academic medicine, unfortunately, we oftentimes focus on individual attributes, individual agency, rather than the things that potentially restrict our individual agency. And so I think that has to do sometimes with the fact that a lot of times clinical investigators will say, well, I have no control over education. I can't change that, right? And so I'm going to start with what everyone else is starting with, and that's race. And I'm going to say there's a difference, and either I explained it or didn't, and that's where I'm going to end. But you're right, we need a paradigm shift.
Yeah, fair enough. Yeah, it's really, really well said.
Any other questions or comments? Okay. So I just wanted to say, in kind of this era of Black Lives Matter and anti-racism, right? We're ultimately scrutinizing the treatment of different groups in the US, right? People are out there protesting, saying that different that groups that have been traditionally underserved in our society, have been traditionally vulnerable in our society, that we need to treat them better, right? That's what people are out there saying. I cannot exist in this society seeing the protests, being an African-American biostatistician, right? Like, I can't exist in this in a vacuum. I am a product of this society, and thus I have to think about, well, how does that impact, how does what's going on in the streets, how does that impact how I do research? And I had to come to a point where I said to myself, like, as biostatisticians, as clinical investigators, as healthcare administrators, we must also scrutinize the treatment of these groups in clinical and translational research too. We need to ask ourselves, are we doing right by the groups that we intend to help, but are we doing right by them? And when I say doing right by them, are we getting them closer to getting the help that they need? Are we getting them closer to getting interventions that can reduce these disparities? Or are we kind of doing research that ultimately further stigmatizes the groups that we intended to help? So let me give you a brief introduction, as I said I would, to causal inference. The majority of researchers, while not always intentional, unfortunately link an association between race and disease with causation, right? And I say this, not to punish us, right? But just say that we oftentimes unintentionally do this. It's part of the training that we get. I don't care who you are. A lot of times this is how we're told to do research. But an association is only a statistical concept. What do I mean by that? Well, let's let E be some exposure of interest and D be some disease of interest. And maybe to keep it simple, the exposure is some binary, you either have the exposure or not, and the disease is a binary variable, you have the disease or not. The statistical relationship will look the same whether the exposure causes the disease or the disease causes the exposure. It will look the exact same. Also, if the exposure and the disease have the same underlying cause, we will still observe an association between the exposure and disease. Causation, however, is not a statistical measure, but it stems from a rigorous underlying theory about the relationship between the exposure and the disease. to test whether an exposure causes the disease, right? We can conceive of a world, and I'm going to take you, I know it's early in the morning, and you're just like waking up maybe. I want to take you for a second on a trip, right? Some crazy, like, some crazy trip to a hypothetical universe, okay?
That's
Because
fine. I've been trying to go on trips, so that's perfect.
okay, this is great. So I want to take you to a hypothetical universe, because we need to go to this hypothetical universe so that we can eventually understand how we work, how we should be doing things on the ground, okay? So in this hypothetical universe, we can conceive of a world where every individual has a potential outcome simultaneously in the presence and absence of the exposure. Okay. Thus, the individual causal effect in this hypothetical universe could be just the difference in their outcome in the presence and absence of the exposure. But I know in reality, we can't observe those two outcomes simultaneously. We just can't. We can only observe one's outcome in the presence of exposure or their outcome in the absence of exposure, right? At any given point in time. So we make very strong assumptions about the comparability of the exposed and unexposed groups, right? So we move from the individual that we were focusing on in our hypothetical universe, and now we move to talking about groups, about populations, right? And so we now are working with what we assume to be exposed and unexposed populations. And the unexposed are really the counterfactual to the exposed. Before I go further, so let me ask you a question. In our motivating example, when we're looking at the impact of race on hypertension, right? And we have Blacks and we have whites in our study. Are whites the counterfactual to Blacks? So in other words, just to make sure that everyone understands my question, are whites Blacks who happen to be white, and are Blacks whites who happen to be Black? Or you can think of a counterfactual in a clinical trial, right? You assume that the placebo group is the treatment group had they not gotten the treatment. And you assume that the treatment group is the placebo group had they gotten treatment. So I'm asking, does that make sense when it comes to race?
I think it fails to take into account all of the other factors that shape the way people get sick, as sort of Dr. Greenwald was saying. It's not just a matter of skin color or not. There's so many other factors. It's not just white people who have white skin or would, as you were describing.
Right. It doesn't actually make sense, right? Like, to say that they're the counterfactual does not make sense given our understanding of the complexity of this world and the experiences that would not be captured there, right? So you're exactly right. So we have to ask ourselves constantly, what is the counterfactual? Right? And if we don't believe that this is the counterfactual, we have to rethink this and rethink the way that we do research. So given this kind of fundamental problem, Holland suggests we are left with two solutions, like this fundamental problem of having this, what we like to do in this hypothetical universe and what we're left to do in reality, right? And Holland gives us two solutions. One is a scientific solution, and that's where you kind of assume that the response after the exposure to the control at an earlier point in time for a given individual is the same as the response after the exposure to the control for the same individual in the current experiment. So in other words, the idea is that, well, you only need to expose the same individual to the treatment in the current experiment. But we know that underlying conditions may not hold true over time, right? And this really, maybe you could try to do this in the lab and assume that all of the conditions were kept constant earlier and currently, right, when you're doing the experiment. But it's really difficult to translate this to real world or uncontrolled conditions, right? So this scientific solution doesn't really work well for us. The statistical solution, as I was mentioning earlier, is that we move from the individual to the population, and we estimate the average causal effect of the treatment or cause over a population. So it contains individuals who are exposed to the treatment and individuals who are exposed to the control. But this still requires a really, really good studies design such that the exposed and unexposed are actually comparable. Okay. But theories behind causation reveal major challenges to understanding what's driving racial disparities in disease outcomes. But I'm going to try to give a little advice here about how we can do this. If our goal is to reduce disease, right, instead of just describing differences, then we must focus on contextual factors like education, like wealth, like you had said, David, that we can plausibly manipulate, right? Discrimination, neighborhood pollution, education, right? Maybe there's particular, biomarkers or things like that, right? Unlike race, we cannot manipulate race. Now, I will say that I have done research looking at skin bleaching among African and Afro-Caribbean populations. And in theory, one might say that there are people who are kind of changing the tone of their skin color. But when I say manipulate here, I'm really saying that race is not mutable, okay? It's not. Measures must accurately reflect the constructs of interest. So a lot of times we say, oh, we're doing a study looking at racial differences and we adjusted for education, and so we're good, right? But at the end of the day, we oftentimes use education is operationalized as years of schooling. But we know that years of schooling will not be a good representative of education if educational quality varies. And we know that due to racial residential segregation and the way in which our society kind of has the system to support, for example, public schools, for example, we know that certain people live in communities where the educational quality lacks. And so what 12 years of schooling means for somebody who gets a low quality education may be very different than what 12 years of schooling means for someone who gets a high quality education. Now I'm saying this, but I'm also saying that I haven't fully worked this out myself, because rarely, if ever, do we have any information on the educational quality. Right. But I'm just saying that we have to think about kind of the limitations of the measures we have, and if there are better ways to operationalize these things. We must also conceptualize or theorize how these constructs operate, right? We're asking a question here. Is race a cause? If I say no, right, well then what is race, right? I mentioned that race can serve really well as an effect modifier to examine, right? But we need to be able to operationalize, and I know some of you may do this, like there's things called DAGs, like directed acyclic graphs, but ultimately you need to have a strong conceptual framework as to how all of these things are operating. And we need to reduce bias due to unmeasured confounding, right? So for example, like the relationship between education and health may be confounded by air quality, lead exposure, crime, collective efficacy, access to healthy food, etc. And we know that the NIH or any funding agency does not give us an infinite amount of resources to study these things. And it's impossible to measure everything with limited resources. But what I say is that maybe we need to look at a snapshot. So maybe we study the exposure and disease relationship in subpopulations homogeneous with respect to a specific contextual construct, right? So if I want to understand the relationship between education and health, maybe I study it solely among Blacks. In this case, I'm looking at education as a treatment here. And I'm saying that if in this group someone is getting more education, does it yield an impact on health? Or maybe I study the relationship solely within a given geographic area where I know that the quality of education is similar. So in other words, we have to think more about how we're doing our studies, because we're not going to be able to tap into everything, but we really need to be able to identify what are particular things or tests. If we were to intervene on X, what would happen? So in summary, if we are to move from describing racial differences to identifying mutable targets for intervention, then race cannot be our endpoint, okay? I'm not saying that it's the end of the world if you start with race, but what I'm saying is you better not stay with race. In most cases, you need to move somewhere else. You need to move to the causes. Okay. But it's a difficult paradigm shift based on how we're taught to do research and how we're taught to even think about patients clinically, right? In terms of all of the things we're supposed to be taking into account. I say we, I'm not a clinician, but all of the things that you are supposed to be taking into account when you decide what treatment you give a particular patient. But the paradigm shift is necessary. And I want to say that baby steps can go a long way. So I give a real world example here where I was asked to collaborate with someone who was looking interested in Black-white differences in postpartum depression treatment acceptability. And one of the things was kind of like, are there differences in whether or not individuals would be willing to take medication for postpartum depression across race, right? And the a priori hypothesis was that stigma was the culprit, that there was more stigma among Blacks around postpartum depression, and thus they would be less likely to want to agree to take medication. However, that hypothesis, it did not stand. And ultimately, I was looking at the relationships, and I actually did not do the analysis. Someone else was doing the analysis, and I was kind of trying to make sense of these things. And I saw that we were getting the same effect estimates when looking at the relationship between Medicaid or insurance status on treatment acceptability and Black race. And so I asked, like, let's look at the distribution here. And what I saw was that Medicaid and Black race were walking hand in hand. The majority of Blacks in the study were on Medicaid. The majority of whites in the study were on private insurance. And so I began to say, well, maybe this is not about race, but maybe it's an access thing. Maybe we have certain groups, depending on their insurance status, who wouldn't even have been given the choice of this particular treatment regimen, and thus have never been exposed to that, and thus maybe say no. And so what I tried to kind of get across, even though I said, let's change the whole paper and let's talk about insurance status. But, you know, it's kind of like, well, this is what we're doing, and we're replicating something that some other researcher did before. So I said, well, let me try to get in one sentence in the discussion where I could say, for example, the vast majority of women in our sample on Medicaid were Black. And some of our findings related to race may be more reflective of insurance status. And my reasoning here is because maybe we need to intervene on thinking about policy. Maybe we need to intervene on thinking about what people get access to depending on their insurance status. And so that was a small win, but ultimately the hope is that we try not to stigmatize the folk we're trying to help, and we actually do the helping. So that is my lecture for you. I'm open to questions. I have questions, but I really want to hear from you, and I want to hear, how does this impact, you know, the research you do or what you've been thinking about?
So this
Hi,
is,
I'm Bruce Sands. Thank you very much for that lecture. It was really clearly laid out and very compelling and very provocative, I think. And I had a couple of thoughts as I was listening to you. And one is that I think historically, and obviously very incorrectly, race and skin color are thought to be surrogates for genetics, which they do not perfectly reflect. That, you know, all people are admixtures of many different genetic populations. But there certainly are genetic bases for some diseases, and we can think of Tay-Sachs disease in Ashkenazi Jews, for example, and that's very deterministic. But at the extreme other end of things, it would be race and skin color, and not just the exposures that the world subjects people to of different skin colors, but also as a surrogate for human behavior and beliefs and attitudes, which is really culture and everything in between. And so, for example, you know, we could talk about Asian race, but we know that Asians are many, many different cultures with many different beliefs, attitudes, and values. And even within that community, of course, those values will differ. So, and not all these things are actionable, especially on the genetic end of things. And I don't know that I have a question here, but just wondering how you think about all these different ends of effects and how they relate to research.
Okay, so I thank you for the comment, and I'm just trying to
it was too much, I know.
Piece together what the potential question here, or what you're asking me to respond to.
Well,
yes.
maybe the simplest thing is talk about culture rather than race, and how we actually study beliefs, attitudes, values, because those do exist in different communities, which may or may not reflect skin color, and, you know, which is race as, you know, colloquially defined.
Right. I mean, culture, I completely agree. And I think it was important what you said, that culture is not homogenous within a given group, right? And so, for example, like, you're looking behind me, you probably see like the Jamaican flag, for example. And so my wife and I are both, in theory, it would be on paper, we are Black, right? But she is born and raised in Jamaica. I'm born and raised in the suburbs, Bryn Mawr, Pennsylvania, and I'm an African American. And so culture differs quite a bit between us. The thing is that you really have to figure out, what is it that you're capturing about culture? Or what is it that you're trying to capture about culture that would influence potentially disease outcomes, right? And maybe there's the mediator there, which is some behavior that someone is practicing. I think that research is really important. I don't think there are enough clinical investigators studying that. And maybe it's because we're we're not taught to really think so hard about culture, because we just kind of, culture informs the way we do things, right? And instead, we're taught to focus on the way we do things. So we're taught to focus on, why is this person not eating the correct diet, right? Like, let's focus on the dietary behaviors without understanding the culture that is informing that. So I completely agree. You also mentioned something about genetics. And I think this becomes, especially, I think before there was a lot of talk about, what does genetics mean in health, or how do we do genetics or use genetics in health disparities research, about being careful, thinking about ancestry, sometimes using kind of principal components in terms of where one's ancestry sits, and instead of race. Or there's others who say, yeah, we should use ancestry, but race is actually tapping into culture. And so we should use ancestry and race. So there are a lot of questions, but I do think COVID-19, and I know I keep bringing this up, but I do think kind of in this time of COVID-19, when I have seen individuals publishing, right, beginning to even think about, oh, well, are the racial differences that we're seeing in COVID-19 influenced by genetics? I've seen, many of us have seen severe backlash, and people saying, no, let's look at all of these other things. Let's look at poverty. Let's look at all of these other things. And so I think that, yes, there are situations where we do see kind of genetic relationships for some diseases, but perhaps that has to do more with ancestry and origin, and understanding that there is heterogeneity, especially in newer populations, admixed populations like African Americans, for example. So I don't know if I answered your question, but I
think you did. I think you did. They're different hypotheses, right?
Exactly.
Genetic polymorphism can relate to risk of disease, but it's also usually modified by the environment, except for obviously kind of Mendelian diseases like Tay-Sachs that I mentioned.
Right. Yeah. Thank you for the comment, though.
Thank you.
Emma, hi, this is Steve Itzkowitz.
Hi.
Thank you so much. You make a very compelling argument about, thinking about association versus causation. And I think most of us don't really feel that race necessarily causes a lot of the conditions that we see medically. A lot of it is access, and as you've been saying. But because we work in the healthcare environment and we do research, and we're trying to even get at improving access, there's so many confounding variables, like you said. There's poverty, there's education, and we try to control for all of these confounders. But there's always going to be more confounders, and you can only control for those confounders that you know. It's the old argument: what you don't know, you don't know. So when you're doing research of this nature, how can researchers really control for everything that's out there? You can't. What comes down to me, really, it comes back to racism. It's all of the factors that we control for, whether it's education, whether it's job, position. A lot of that is influenced by how society has set that up. And so, even when you find differences in education, et cetera, we have to ask ourselves, why is that? And then when you get to the why questions, and you get deeper and deeper and deeper into why, I feel that it often just comes back down to pure racism. Racism meaning people in the community that have not been allowed access to power. So we can do, like you said, okay, what are you going to do about it? Like you said, you can find these problems, but what are you going to do about it? And I think what you're going to do about it really still comes back to, what are we going to do about racism in this country? Because that's the construct that is set up all of those disparities in health, education, jobs, etc. How are we going to factor racism into our work?
Well, there are metrics to evaluate racism. You know, David Williams, for example, a particular scholar, has spent his whole career trying to figure out how we measure racism. How do we measure kind of structural systems, right? There are folk who do that. And maybe it is us needing to actually collaborate with folk who are doing that, right? But you're exactly right that it's racism. My argument is that then we need to learn, how do we study racism, right? And then if we're doing this looking at kind of our patients within the health system, then we kind of need to think about, well, then if we're studying this, how do we as a health system contribute to a potential intervention, right? The intervention can't really just be like, okay, well, let's just teach people who are subjected to racism to better cope with racism, right? That can't be the intervention. But it can mean that, you know, I think about something like telehealth, right? And I think about the idea that there are many people, as we moved into a system of telehealth, right? Many people were left behind in that, right? I've done some research that looked at telehealth disparities in that, or telehealth differences, in which, you know, most Black patients weren't coming through the health system related to COVID encounters through telehealth, right? Showing up in the emergency department at times where they could have gone through telehealth. Well, the question is about access. Now the health system wants to expand telehealth, right? And you're bringing up a particular case where, look, many people don't even have internet access, right? So if we as a health system are expecting particular communities to move in that direction, we have to consider, are there particular structures and isms that would prevent folk from being able to have access to that, and what we as a health system would need to do to change that? What type of investment do we need to be making in the communities that we serve that would counter the lack of investment that has been given to these communities by governments and everyone else? So I know that that's a big ask, like, okay, well, you want to know about racism? Let's study racism. But I think that we can try to do more. I think we can try to educate ourselves. We can learn about people's metrics for racism and try to go from there.
Hi, Dr. Benn. This is Christine. I'm one of the second-year GI fellows. Thank you for this fantastic talk. A question I have in kind of the study of these social determinants from a research perspective is, I feel like a lot of these social determinants are related: your income level, your education level, where you live, and how it relates to culture and your beliefs and how you perceive information and approach your care. So how do you tease out the specific effect of one determinant when oftentimes these determinants are interrelated?
Yeah, so I mean, look, this probably also taps into this idea of unmeasured confounding, and all of these things. There's a lot of things, right, that are related, that are important, but ultimately research is really a snapshot, right? It's a snapshot. It's a very simplistic view of the complexity of the real world. And so I think the best we can do is try to focus on a specific factor that we are interested in testing that hypothesis, understanding that that particular factor may actually be a mediator. So we're kind of looking down the pathway, right? And understanding that there are particular things that may precede that. And we may not get to what's preceding it, but we're getting at something within that pathway. And that's kind of our little piece, our little contribution to this bigger story of why we are seeing a particular problem. And then we kind of just keep building. We build on that, or we build on what others have done. So I know I am not giving like concrete answers here. They feel a bit abstract, but I think we can focus on only what we can focus on. Acknowledging that this may be influenced by 25 other things. And that we need to also begin to understand those things, because there's different points that we could be intervening on in the pathway. And some of that is going to be kind of individualized interventions, and some of it is going to be more structural type of interventions. I hope that helps, Christina.
That does, thank you.
Dr. Benn, thank you so much for this very thought-provoking, I think, discussion. I think it's made a lot of us reflect on how we approach race, ancestry, social determinants, all of those confounders as we move forward. And I'm really glad you came to our GI Grand Rounds, because a lot of what we do does incorporate, a big focus of our division really has been on pushing back against disparities, and this really does help, at least in the research and data gathering perspective of it. So thank you for joining us.
Yeah, and I look forward to the opportunity to get to collaborate with you potentially in the future.
Great. Thank you so much.
Thank you.
Thank you.
Have a good day, everyone.